Welcome to AETCM emergency channel. We are going to discuss a case of a patient with altered sensorium with reduced response for 1 day duration and a known case of CLD. Sir. Shall we start, sir? Yeah. Patient on arrival, we had was responsive to pain, sir. In the first 10-second assessment, we had seen the GCS as E1, V1, M5, sir.
Ideally, before a patient arrives, you should be prepared.
Yes, sir.
Okay.
Yes, sir.
You're talking about an altered sensorium case.
Reduced sensorium.
Excited state or a depressed state. You don't know exactly what exactly it is.
Yes, sir.
The patient has arrived to the ER. Before that, you should be prepared. So wear your PP and all precautions. Make your team ready.
Yes, sir.
Assign airway to a particular staff, breathing to a particular staff, circulation to a particular staff. Okay. Make it ready and then you approach.
Okay, sir.
Okay. So patient has arrived.
Before arrival only, everybody has to be assigned a key role in the primary assessment.
Yes. So now we are going to move to the primary survey, right?
Yes, sir.
So patient has arrived. Okay.
Sir.
Yeah, what we told gains importance, especially when we get information like the patient is being transported in an ambulance. So your EMT team gives you a heads up, or the patient has just reached your entrance and you're seeing a report. So that will be the time to trigger this preparation. Okay.
Sir, in the first 10-second assessment, the GCS was E1, V1 and M5, sir. Immediately...
Actually, you're not supposed to go like that.
Okay, sir.
Okay. You have already won the PP and all. It's always A, B, C, D, E pattern.
Okay, sir.
Patient has come there. It's always the airway first.
Okay, sir.
Because if you say GCS is this thing, means straight away, it means that you have straight away moved to disability. You haven't addressed A, B.
Okay.
See, like, we go by the rules, A, B, C, D rules. First of all, airway.
Yes, sir.
So what an airway?
So primary survey in the airway, sir, airway was patent as there is no anatomical deformity, no pooling of secretions, no snoring.
You already told it's patent.
Yes, sir.
So what patent means? What all things you are looking for?
With the patents, we are looking
right now you are not sure whether the patient is like ACLS case, a medical case, or a trauma case. It's a decreased sensorium.
Decreased sensorium, yes, sir.
Whether it's secondary to a trauma or whether it's secondary to some medical problem, you're not sure.
Yes.
So airway. Okay.
Yes.
No. So what all things you are looking in airway?
So first is look at the anatomical if the tongue rolling or if there is any pooling of secretions, if there is abnormal
any intrinsic problem or an extrinsic problem. Intrinsic means in the sense like large pool, like the large tongue, distorted anatomy, any facial any abnormalities which may compromise like intubation and all. Then
or any abnormal sound production.
Pardon?
Any abnormal sound production like stridor if is.
Stridors. Okay. Stridor means what?
Inspiratory
or expiratory? What? Which part is involved?
Trachea and
the upper
airway.
Okay. Is it a high pitched or low pitched sound?
High pitched.
It's high pitched.
High pitched.
There's something called a strutter also. That is low pitched. Okay.
Yes.
So you're looking for the airway, the tongue, any tongue swelling is there or not. Then basically look, feel and listen. That is what you're looking for. Something, feeling for something, listening for something else. Okay. So looking for pooling of secretions, the extrinsic pooling of secretions, then saliva.
And if traumatic.
Yeah. Pooling of secretion happens in which state? Which an example? One poisoning case, what poisoning? Organophosphorus. Poisoning will be full of secretions, right?
Yes, sir.
Okay, so before that is the importance. Patient has come to you like that. So if you do not wear your PP without your gloves, you straight away go and touch the patient. All these secretions will be on your hand. So you yourself will be poisoned. Got it?
Yes, sir.
Okay. So secretions, pulling of secretions, then stridor.
Just adding to that, he told about increased production of secretions, right? There could be just inability to swallow also. Can you cite some examples?
Inability.
Any primary brainstem issues? Okay, advanced Parkinson's.
Okay.
Cervical spine issues. So there could be neurological issues which can affect the swallowing mechanism itself. That itself can lead to pooling of secretions. Okay.
continue.
So then in the breathing component, sir.
No, you haven't dealt with it. Like airways patent, you have looked for all these things, any dentures, other things you have looked for. So right now we have reached a conclusion that the airway is patent, right?
Yes, sir.
Patent. So is he producing sound or something?
No, sir.
Not producing sound. So how can you say it is patent? You're not hearing anything.
Yes,
Patient is
sir.
simply lying like that. So
Yes,
how is it patent? What?
Because of the other no anatomical deformity. No,
Was he able to vocalize?
No,
Can you ask
sir.
his name and all?
No, sir.
So that means it is not patent. Huh? Or else
We
you have
need to put in the oropharyngeal if
Okay, if it
we
is
can
not
check
patent, if you feel it is not patent, you try putting the oropharyngeal airway.
if it
Suppose
is.
patient is gagging after putting the OPA.
Yes, sir.
Okay,
Then we can say that airways.
then you are not supposed to keep the OPA there itself. You're supposed to take it out. If the patient is having a gag, in that case you can put a NPA. Got it, no?
Yes, sir.
If the patient is tolerating a OPA,
OPA.
it means that he
Gag
is for
reflex.
impending airway compromise. So make sure he is intubated as early as possible. Because gag reflex is gone.
Yes, sir.
Got it, no?
Yes, sir.
Okay. So after that, what will you do? Once you have put the once you have put the nasopharyngeal airway or OPA, what will you do? Suppose you have placed the NPA.
Yes,
What
sir.
will you do?
Then we assess again the airway and go.
No, you put a NRBM with high flow O2.
Okay.
Okay. That is the end of it. That is intervention you are doing.
Okay.
Once you have completely assessed, like only after complete assessment of the airway, you're supposed to intervene. You have completely assessed the airway. Like the patient is not vocalizing, so put a NPA. So airway is patent right now, and then you have placed a
NRBM.
NRBM with high flow. So how do you like measure the NPA length?
So from
What length is?
from the tragus to the
Here to
angular.
here to here. No?
Yes,
Here
sir.
to here. What about the OPA? How do you assess?
OPS from the
Here to
angle to the angle of the mandible to the.
That is about OPA. That is how you. So how do you insert OPA? You can actually go like the 180-degree approach is there. You can straight away go like that and turn 180 degrees, or through the side also you can go like that and turn to 90 degrees. Okay. Then NPA.
Just like Ryle's tube, we need to.
Yeah. The bevel should be like inside facing the septum, and then you're supposed to, after applying gel and all,
Yes, sir.
proper gel and all, slowly place it inside. Only thing is, if the patient is having some sort of a trauma or anything of that, like mid-phase fracture or something of that sort, then you're not supposed to place. If there is any other contraindication. Okay.
Yes, sir.
Okay. So you have dealt with the airway.
And after intervention only we need to.
Yeah. As a complete assessment, then intervene and intervention. So airway is taken care of right now.
Yes.
Right. Suppose you have placed the NPA, NRBM high flow O2 kept. Then moving on to
Breathing.
B.
Breathing components.
B. What all things you look?
So in breathing, first saturation, we'll check saturation of 97% at room air, sir. And then respiratory rate of 20 per minute.
Actually, in breathing, you are supposed to expose the chest.
Yes, sir.
Connect all the monitors, including the BP, saturation probe, everything you have to expose. Okay. Expose, then you check, basically you check for the RR as well as the SpO2. If the RR as well as the SpO2 is fine, grossly you can say the B is clear.
Clear.
Okay. Got it. So what is the RR in there?
So respiratory rate is 20 per minute, sir. And saturation was 97% at room air, sir.
So grossly
They're fine.
it is okay. The breathing part is fine.
Yes, sir.
Okay. Now what all specifically you look
On
for?
inspection, the chest was bilaterally
Inspection of
moved.
the neck first,
First neck.
and then chest.
Chest.
Okay. Neck.
Neck, the trachea looks central in position. And then the equal movement of the chest on
Neck veins are
bilateral.
dilated or not? Because we will talk about other things, pneumothorax and all these.
Yes.
Is the trachea central? Are the neck veins dilated? Okay. Then
Then
go down.
The movement of the
Is
chest.
there any gross abnormality in the chest wall? Is it rising inspection wise? Is
Yes,
the gross abnormality, is it rising equally? Then palpate. Inspection, palpation. Then chest excursion, is it equal or not? Then percussion, look for whether dullness is there or not. Okay. Then
Then
auscultation.
auscultation. Yes, sir.
Got it, no?
Yes, sir.
Okay.
On inspection.
So auscultation, everything is clear.
Bilateral air entry chest was equal, sir, and chest was clear, no added sound, sir.
Okay.
And then next on the circle, nothing was to intervene in this part. Next to
So
circle.
B is clear.
B is clear, sir.
Okay.
Next in circulation component, sir. The BP was 100 by 60, sir. And then pulse rate was 68 per minute.
So grossly in C, you're supposed to look at heart
Pulses.
rate, BP, CRT.
CRT, yes, sir.
Okay. And you're supposed to place a 2 large bore IV cannula also. Okay. If heart rate, BP, and CRT is normal grossly, you can say the C is clear.
Yes, sir.
Okay. Immediately after assessment of that, you place the
Two IV more cannula.
and once you place the cannula, what all things you're supposed to draw?
Adjuncts for the primary survey like ABG and
Yeah. All hematology, biochemistry, blood gas, blood
electrolytes.
culture, blood gases, all toxicology screen, and arterial blood gas.
yes,
Okay, hematology, biochemistry, blood culture, blood gases, and toxicology if needed in this case. Because sedated, like you're told, it's a decreased sensorium.
Yes,
Decreased sensorium, basically falls under the depressed thing, no?
yes, sir.
That sedative
Confusion
panel, some sedative depressed panel. If it is a toxicology case, we'll have to address that also, because depressed sensorium can be because of a medical problem, can be because of a surgical problem, or trauma or anything of that. Could be because of a metabolic problem, septic problem. It could be a toxic encephalopathy or any IC bleed. So many things are there. Or it could be a psychiatric cause also.
Yes.
Okay. All right. So you have drawn all the blood samples.
sample.
Then
Commenting upon the pulses, they're regular in rhythm and all peripheral pulses are
regular into okay.
and equally felt all the peripheral pulses.
Okay.
Then disability.
No. Palpation, auscultation, heart sounds, and all you haven't told. No?
Yes.
Palpation wise, where exactly is the apex beat?
Apex. Sir,
Because circulation can, if there is any problem in suppose BP is low, suppose it means that there is some problem like hypovolemic, obstructive, distributive, cardiogenic, some shock is there. Okay. In that case, for circulation, you'll have to like you have examined the B part. So grossly B is clear. There is no hemothorax, pneumothorax, nothing is there. So move to the abdomen. Is there any tenderness guarding rigidity? Rule out like hemoperitoneum. Okay. Is there any gross other limb central? Is there any gross bleeding or anything of that sort? Okay.
Active bleeding.
Active bleeding. So that part, everything is one by one. You will have to knock out the DDs. Like whatever is life threatening has to be addressed in the primary survey itself.
Yes. Okay. So on inspection of this, there is no any like bruises or contusions or the abdomen, no long bone active site of bleeding is present.
Because I'm telling in this way because you're not sure what the history is.
Yeah.
Suppose you already know it is a hepatic engulf because you're already biased. That means that you're already biased. A decreased sensorium case, you're already biased. You know that somebody has already told it's a CLD, DCLD, and with hepatic engulf. So your brain is not working properly. You're like just addressing one concern, one hepatic engulf concern. We've got lots of other causes for decreased sensorium.
Yes.
It could be because of a bradycardia or it could be because of a tachyarrhythmia. So many things are there, right?
Yes.
So grossly, that part is dealt. Okay. And on auscultation?
Auscultation.
Auscultation, you're looking for the heart sounds.
Yes, sir.
Is there any muffled heart sounds or whether it's normal, regular?
S1, S2 is heard and no any added murmurs. Sir.
In the abdomen, the aorta, is there any bruit? You're looking for abdominal aortic aneurysm rupture kind of things. No? In C can be affected because of a AAA rupture can affect C.
Yes.
And that itself can cause decreased sensorium. Decreased perfusion to the brain, that itself can cause decreased sensorium. Because till now you haven't understood what exactly the cause of a decreased sensorium is. You have just placed an NPA, put an NRBM, move to B, move to C. Okay.
Yes, sir.
All right. Okay. So where exactly the problem is, you haven't understood. Is it in the problem with A or B or C? Okay, D comes then, right?
Okay.
Okay. So C. So C part is clear right now.
C is clear.
Now?
Sir, regarding disability, sir. GCS was even V1.
What about the blood? The reports, blood. We have already drawn samples, no?
Okay, sir.
The ABG, like ABG samples.
And the GRBS is 150.
No, that is a disability.
Disability. Okay,
What
sir.
about the ABG?
ABG showed a respiratory alkalosis, sir.
Respiratory alkalosis.
Alkalosis.
So that means patient is hyperventilating. You told respiratory rate is 20.
Yes, sir.
Okay. So how come respiratory alkalosis?
Because the pH was 7.46, sir. Just a slight.
4.46. Okay. PCO2, PCO2.
PCO2 is within the normal range, sir. 33.
Okay.
30. It was 36, sir. PCO2.
7.46 pH. PCO2 36.
And
Bicarb.
bicarb was, sir.
What is the normal pH?
7.35 to 7.45.
4.5. So it's slightly on the higher side.
Slightly.
So alkalosis.
Yes, sir.
What is the PCO2 here? What is the normal PCO2 range?
PC 35 to 45, sir.
What?
It was 36.
mmHg, no?
Okay. Yes, sir. PCO2 36 mmHg.
36. So it's on the lower side.
Yes, sir.
Okay.
And
So probably he's hyperventilating.
yes, sir. But
Some amount of
tachypnea.
tachypnea will be there. So naturally, what will you expect in bicarb?
Bicarb would be the lower, sir.
So generally, bicarb and PCO2 both goes in the same direction.
Same direction. Yes,
So you actually expect bicarb to be on the slightly on the lower side.
yes, sir. It was 23, sir.
Okay, all right. Okay, slightly on the low side. Basically, it's like trying to compensate. No? 1.46, like about trying to compensate.
Trying to compensate.
All right.
Along
What
with
about the lactate?
lactate was 3.7, sir. Increased.
3.7. Okay. Okay. Some
Lactate was-
hypoperfusion, some issues there somewhere.
Yes, sir.
All right.
And bilirubin was 31.8, sir.
Okay. What about the PO2?
Sir, PO2 taken. I hadn't entered it, sir. It was
Is
around 7.
this a VBG or ABG?
ABG, sir. That
ABG.
ABG, sir.
Okay. All right. Okay. So what is the
Yeah, just a few additional things. So now you have a pH which is more towards the alkalotic side with the lactic elevation, right?
Yes, sir.
And you are telling that the bilirubin is also elevated. So definitely keep hepatic causes of lactate elevation in the DDC at this point. Just because of liver failure itself, lactate can go up. Okay. That can be hyperlactemia itself. There's a difference between hyperlactemia and lactic acidosis.
Okay, sir.
Okay, here lactate is elevated. Probably hepatic cause should be considered at this point. Okay. And electrolytes, is
Sir,
it relevant in this
potassium was
case?
2.2, sir.
2.2, that's fine.
And sodium 133, sir.
Okay. Potassium is definitely low. That has a relevance in hepatic encephalopathy.
Yes, sir.
But moreover, I am concerned about the sodium also.
Sodium is 133, then slightly
We'll
lower.
definitely need to wait for the lab values to come. But potassium, we will come back to it. Once the lab values are available, we will discuss it again.
Yes,
Okay.
The other metabolite in ABG, serum creatinine was 1.05, sir.
Yeah.
Yes, regarding now the disability, sir, the GCS was even
because the
V1.
PO2 and all this is relevant? It's relevant because in some poisoning,
Okay, sir.
carbon monoxide and all these things, no?
Yes.
Very relevant. That's why I'm asking all these things. PO2.
Okay, sir. Disability wise, GCS was even V1 M5, sir. And the pupil right side was 2 mm.
GRBS first is disability.
Okay, sir. GRBS.
GRBS,
GR
GRBS, GCS, pupils, lateralizing signs.
Okay.
What is the GRBS?
GRBS was 115 milligram per deciliter, sir.
Okay. Okay.
Then GCS was even V1 M5, sir.
Even V1 M5.
When
This is
the
7 by
response
15.
to
7 by 15.
Yes, sir.
So that means airways compromised patient is to be intubated for sure, no?
Yes, sir.
Patient is not talking. Yeah, GCS is
Low, less than
less than
8.
8. Okay.
Risk of airway
Risk of
compromise.
airway compromise is there. The gag and all you haven't checked anyway.
No, sir.
Okay, all right. Then pupils.
Pupil, sir, right side pupil was 2 mm and reactive, sir. Left side was 2.5 mm and sluggishly reactive.
Okay. So what is the relevance of checking a pupil? Decreased GCS, pupil.
Hemorrhage.
Yeah. Any IC
IC
bleed, proselyte,
pressure.
IC bleed, and then some poisoning. Decreased, depressed, meiosis, mydriasis. Got it. No? Okay. Okay.
So then the exposure, sir. Patient was febrile.
What about lateralizing signs?
No letter. I mean,
Is
he
he
was.
moving all the
All the forelimbs were responsive to pain.
to pain? He's moving all
All
the.
the forelimbs.
Okay. All right. Okay. Then
Then exposure wise, sir, patient was afebrile, and to prevent hypothermia, we
another thing which I have forgot to mention is regarding inspection of airway and breathing. In the breathing part, the cyanosis of the tongue. Breathing, I forgot to mention about that. Okay.
cyanosis of
Cyanosis, whether it's there or not. Okay. Then right now we are in D.
disability,
Okay.
GRBS, GCS, and then pupil and the
Pupils and lateralizing
lateral
signs.
signs were
Okay.
there. Now regarding the exposure, exposure patient was afebrile, and then to prevent hypothermia, we provided a blanket.
Yeah.
That's it.
Rash, any rash?
Okay.
Any rash? Is it in sepsis and all? Any body in the rash, anything of that sort is there? And also in exposure, other things are any diaphoresis, excessive sweating,
Okay.
any excessive secretions, or any needle marks on the body. We don't know whether it's he's some
The,
drug abuser or anything of that sort. Any cannulas
yes, sir.
or no? Okay, any like any tablets or anything in the pocket.
Okay.
Is he having some this thing? In case of adrenal insufficiency and all, no, like Addisonian crisis and all, the patient some at times patient may have a alert in UK and all. You got an alert medical bracelet is there,
Okay, sir.
whether it is there or not. So these are all these things can come with decreased
Sensor.
sensorium and all. Okay. Then
So in the primary survey, we had seen there is reduced sensorium. The main
so finally A B C D E, and you prevented hypo. What is the temperature?
temperature was normal body temperature,
Okay. So
98.6.
hypothermia itself can cause this thing,
Yes, sir.
decrease sensorium. Also, if it is a hyperthermia, that also can cause. What are the causes of this thing? Hyperthermia and decrease sensorium.
Heat.
Some what are the things? Neuroleptic
NMS.
malignant syndrome and all these
Neuromalignant
things.
syndrome.
Because until now you don't know what the history is. You are still in the primary survey assessing the life-threatening things.
Okay.
Okay. So once you have finished with A, B, C, D, again you will have to reassess
Yes, sir.
the airway. Then now, when you go to A, you're supposed to intubate at that point because your other things you have already dealt with. So you intubate, then again assess B, C, D, E.
Yes, sir.
Got it? No?
Yes, sir.
So we have addressed all the what life-threatening
Life-threatening causes.
causes. So once that is done, move to
Second
survey.
survey.
Adjuncts to primary survey, you can add at that point of time. In C and all, you can ask for an ECG.
ECG. Yes, sir. In there were some ECG changes, sir.
Basically, in adjuncts to primary survey, 2 Gs, one ECG, one ABG, 2 tubes, one RT, one Foley's.
Foley.
Okay.
Okay, sir.
In trauma and all, X-rays are also advised for pneumonia. If suppose you feel something is wrong with the B part, you can ask for an X-ray. See for if there is any pneumonia or anything of that sort or anything. Okay. Then you are move to the secondary survey. Secondary survey,
Detailed history.
detailed history, no? The ample history plus
The examination.
systemic examination. If it is a trauma case, you will have to do head to foot examination. If it is a medical case, you can go ahead with the systemic examination, CVS, RS, GIT, whichever is relevant in this particular this thing, presentation. Okay.
Sir, like in the adjuncts wise, in the ECG wise, sir, the ECG, the heart rate was 61 per minute, and there was a normal PR interval, sir. No T wave inversions, no ST depression, but apparent long QT interval was there, sir.
Long QT interval.
Yes, sir.
Okay. How much?
632 milliseconds was the QT interval.
Okay. Okay. All right. So how do you calculate the QT this thing interval?
Sir, like starting of the Q wave to the T.
630 something.
Yes, sir.
All right. So what do you think the causes?
Hypokalemia.
Hypokalemia. Okay. What are the causes?
hypomagnesemia, hypokalemia, and
Drugs and all.
drugs like AV.
Amitriptyline,
Oh,
tricyclic.
okay. TCS. Okay, TCS. Okay. Why all of a sudden you thought about hypokalemia?
Because in
Because ABG showed how much was it?
2.2, sir.
2.2. Okay, all right. So in that case, you're supposed to address the potassium there itself because hypokalemia itself is a killer.
Yes, sir.
Okay, so you should correct hypokalemia at that point itself.
Yes, sir.
All right. So the interventions after primary survey. Okay.
Interventions after the primary survey was the potassium corrections of 40 milliequivalents in 100 ml in S over 4 hours. And then, sir,
All other
even
electrolytes are
CBC.
sent, no? Magnesium and everything is sent.
Yes,
right?
sir. CBC and CRP point of care was also done as the adjuncts. In that, we got WBC as 7.4, sir. Platelets are only 44. And hemoglobin 16.5 and CRP of 21.1, sir. So,
Thrombocytopenia is there.
so arrangement of 4 RDP was given at that
So
point
causes
of
of
time.
thrombocytopenia?
Causes of thrombocytopenia at this point, it can be liver failure causing the thrombocytopenia. Apart from that, if there might be any upper GI bleed, we don't know any loss of bleeding. Any
Upper GI bleed causing thrombocytopenia. It's cause anemia, right?
yes, no anemia. Sir.
Okay.
For 20,000 plus, ideally you need not transfuse. Okay, here, since you have arranged, the only thing will be if the patient develops symptomatic things.
Okay.
For intubation and all, ideally there is no need to transfuse. Even for central lines and all, CLD patients at times 20,000 is acceptable once we are doing ultrasound guided. We got the INR values also, or
No, sir,
not yet? No,
yet,
fine,
not yet,
no
sir.
problem. So that will be the thing. But if you are suspecting any other internal hemorrhages, intracranial hemorrhages, things
CT
like that,
brain was also plain CT brain was also sent for, sir, at this time, and the report was no IC bleed in the brain. Sir.
then at this point there is no indication per se to transfuse platelets. Okay.
Yes, sir.
So the mystery behind the decreased sensorium is still a mystery. You haven't understood like till now. Okay.
Yes, sir.
So the ample history. So move on to the
Secondary, sir. So the case is a 42-year-old male, sir. He's a known case of CLD, sir. He was diagnosed first in 2014. He had an episode of DCLD with portal hypertension in 2020, sir, with child C and MELD sodium score of 19. The etiology was
child. What is child?
child pug score.
Child pug score. What all things will come under child pug score?
We have bilirubin as a component, and then
Encephalopathy, bilirubin, ascites, albumin,
albumin,
and PTN.
PTN.
Based on that, you decide which cell A, B, or C.
C. In 2020, he had this episode
This
of
is child C.
Child C, sir.
When was it child C?
2020, sir.
2020.
7/10/2020, he had a decompensated liver failure, sir. At that time, and the cause etiology being the ethanol, sir.
Oh.
And there are no other comorbidities, sir.
The other thing is, now you're discussing about decreased sensorium. Straight away, you have jumped to the past history.
A known case like comorbidities.
Because this is what you told it's a decreased sensorium. So you're supposed to mention in detail what the decreased sensorium is, the history, HOPC of that decreased sensorium.
Okay, sir.
So who saw it, when it happened, where it
Yes,
happened,
okay.
why it happened, how many times it has happened in the past, what happened before the decreased sensorium, during the decreased sensorium, after the decreased sensorium, what was done for that by the bystanders. So all these things have to be addressed in
The
HOPC of decreased sensorium.
Okay.
So when it happened?
So patient was in a lowered altered sensorium, not responding to verbal commands since past 1 day, sir.
Okay. Who noticed?
The parents have noticed, the parents of the patient had noticed that he was not responding since last 1 day, sir.
1 day. So what was he do at that point of time? Where was he?
He was
When
at
they
home.
noticed it is in like what was it like, lying down or?
He was at home. He was actually discharged from an outside hospital, and they had brought him home. After that, he started developing this lowered response and reduced response, reduced sensorium.
I mean to say, like, what was he lying on the bed, and then when
He was
when the
lying.
bystander
He was lying, sir, lying in the bed at the home.
with in decreased sensorium.
Yes, sir.
Okay.
So actually, like the patient had a binge alcohol consumption for the last 20 days at home, sir, and he stopped taking any medications.
That's
And
about the past history, no? You're
yes,
talking
sir.
about the decreased sensorium.
Okay, sir.
Once you have spoken in detail about the decreased sensorium, then you go back and like go to past history. Say patient is a known CLD for so and so for the last 6 or 7 years, and is in child C since 2020. Okay,
Yes.
and right now recently had a binge alcohol intake. That's how you go systematically and you should go in an organized fashion.
Yes.
Whichever complaint you're making, this thing, that chief complaint, explain in detail about HOPC of that complaint, and then go to past history and say this is the background, CLD and whatever, stroke or whatever you can mention, the binge alcohol when it was taken. Okay.
He was at home lying down at rest, like at the bed, and then the parents have noticed that he was having reduced sensorium, so he was not responding to any verbal commands.
Was he in a past urine and
No,
because
sir.
even seizure
Yes,
can cause a
sir.
decrease
Decrease
sensorium.
sensorium. There was
Hyponatremia
no.
can cause a decrease sensorium.
Yes, sir.
Hepatic handcuff can cause. Septic handcuff can
Can
cause.
cause. And
Okay,
yes,
icy bleed can cause. Poisoning can cause. There are so many
yes, sir.
DDs, no? Okay. So was there any
No,
soiling of the thing?
no fecal incontinence or no urinary incontinence, sir. There was no any tonic-clonic movements previously, or there was no uprolling of eye.
Previously.
Means during that reduced sensorium time, there was
That is reduced sensorium is usually after a tonic-clonic.
yes, sir.
It is a
So
post-ictal state, no?
okay, sir.
Probably the bystander wouldn't have seen that episode of seizure.
Okay, sir.
Probably that is the most like. Otherwise, they'll say patient through episode of GTCS seizure and all, and afterwards gone into post-ictal state. That is the normal way they say. If at all they had seen the episode, now
Yes,
they have seen this patient is lying on the bed unresponsive for some reason which they don't know, and probably they took and that has been persisting for last 24 hours, and for that patient is for the last 24 hours they kept the patient at home or gone to some
at
other
home
hospital
only,
or,
sir. I mean, they had traveled and they had come here.
okay. Okay, so 24 hours they have been doing nothing, and
Yes, I mean, suddenly he did not become unresponsive. There was a gradual loss in the sensorium, sir.
okay, so the parents did not do anything for that.
No, sir.
They just watched.
Because here it was diagnosed as CLD, and last time DCLD was treated in Amrita Hospital, so they had got him here again, sir.
Okay. Okay. So you have spoken about this thing, HOPC, and then associated symptoms. Associated symptoms, what all things?
No urinary.
No, you're talking about decreased
Decreased
sensorium.
sensorium.
Talk about the CNS, musculoskeletal, because we want to know whether it's something wrong with the brain. Any neck stiffness, any headache prior to that. These kind of things.
Yes.
Okay. Then any meningitis, encephalitis. These are the things which we want to know. Any problem with the brain? Okay. Any problem with the musculoskeletal problem? Any problem with the GIT?
Yes.
Any constipation?
There
Any
was.
loose stools? Any abdominal pain? Because child CCLD patients will have all these things, no?
Yes, sir.
Okay, if there is constipation, we will expect a hepatic encephalopathy. If it's a diarrhea, loose stools, gastroenteritis, sepsis, septic encephalopathy. Okay, and if there is an abdominal pain, child C patient will have a SBP. SBP chance is very high.
Yes, sir.
Okay, so these are the things you should ask in history.
Okay.
Whether there's any neck stiffness, headache, vision problem, hearing problem, vision problem, or anything of that sort, body pain, weakness, muscle pain, anything of that sort, and any swelling, and then abdominal discomfort, abdominal pain, loose stools, diarrhea, any genitourinary problems, any change in urine or urination, urine color, any discharge from the site. Okay, then what? Serious, any other problem related to chest pain or anything of that sort, and also the RS, because PCO2, or if suppose the patient is having some PCO2 buildup, that itself will cause a decrease in sensorium. No? Any respiratory problem, any wheeze, cough, shortness of breath, anything of that sort is there or not? If there is a pneumonia, that itself will cause a septic encephalopathy. Okay, then
Rest of the HOP
then
has
rash, any
no history of any melena, fever,
Ah.
vomiting, abdominal pain.
accepted. So that means that you're not. There is no like no constipation also.
No constipation, sir.
Okay. So as of now, there
this-
is only hypokalemia, which will cause a NCUF,
And yes,
hepatic NCUF. Other things are not there.
yes, sir.
You mean to say like that?
As of now, yes, sir.
Then CRP is on the higher side, no?
Yes, sir.
So some
20.
sepsis is there somewhere which you don't know where exactly it is.
Yes, sir.
Okay.
So for which past history we would be
Okay.
requiring.
Alright.
Sir, so the patient had been binge drinking alcohol for last 20 days at home, sir. He was not taking any medication, and in the last 20 days he was hospitalized in multiple local hospitals, sir. The history wise he was saying that he was taking DNS infusion from the local hospital multiple times, sir. And 2 days back he had been admitted in government medical college, sir, with
That means hypoglycemia. Patient is having
hypoglycemia, recurrent
because
hypoglycemia.
of CLD.
Yes, sir. And 2 days back, he got admitted in government college with complaints of generalized weakness, fatigue, and distension of abdomen, sir. No discharge summary was provided, so we had no idea what medication or treatment was received. Post discharge from that hospital, on arrival at the home, gradual loss of sensorium was noticed by his parents, sir. During that time, there was no any history of GI bleed or constipation or melena, fever, or any abdominal pain or any seizure or focal neural deficit, anything, sir. There is a history, sir. No clinical examination.
No allergies. Past medical
Sir,
history,
no other,
allergies.
no known drug allergy, and last meal was more than the
No
24
surgical
hours.
histories in the past. No recent interventions done. Ultrasound, scopy, ascitic fluid tapping, endoscopy, colonoscopy, nothing done so far.
I mean, in 2020, for when he was in decompensated liver failure, then there was an OGD scopy
Nothing
done.
recently.
Nothing in the
No
recent.
recent travel.
No recent.
No recent travel. No food intake from outside. No like social sexual travel history. Any drug abuse or anything of that sort. Nothing. No?
But yes, sir, he was abusing alcohol as such.
Abusing only alcohol, not mixed with.
No mixed with other substances.
Okay. Was he off alcohol? Like, is he like continuously? drinking?
Continuously drinking daily. He was even skipping the meals. He was just binging on alcohol, it seems.
So for the time being, we can say like examination wise, anything significant?
Yes, sir. Icterus was present.
Basically, features of CLD.
Yes.
CLD is there. Okay. CT brain ruled out a bleed. So we are for the time being, your DD is hepatic NCUF, grade 4.
Decompensated liver failure with
Grade 4 hepatic
grade 4
NCUF.
hepatic NCUF.
Secondary to hypokalemia, which you're planning to also sepsis.
Yes,
So you'll treat the potassium and then
finding out the source of infection.
okay. And the source of infection and the first dose antibiotic to be given within the first hour after taking blood cultures and all these things. Okay, if there is an SBP, tap and find out diagnostic. Tapping has to be done. Rule out a SBP. Okay. How do you diagnose an SBP? More than 500 cells per microliter. Okay. So finally, you give an antibiotic, and what happened to the patient right now? Is he okay now?
He had discharged against medical advice.
Discharge against medical advice. Okay.
Actually, the patient was not able to, the potassium level was not balancing multiple times. The correction was keep on going on, sir.
Just
Apart
go through
from
one-
that, source of infection was urine. UTI was present, sir. On ultrasound, we found that there are bilaterally in both the kidneys there are calculi present, sir. Along with that, in urine routine, there is this pus cells, high increase in pus cells and UTI
Basically, in questions about these things, hepatic NCUF, you're supposed to know Westhaven classification. Newest, this thing, Westhaven classification of encephalopathy. Then the child scoring system, you'll have to understand what all things will precipitate hepatic encephalopathy.
Yes.
And melena and all these things, hypokalemia, melena, sepsis, constipation, all these things.
High protein diet.
High protein intake, even hypomagnesemia, all these electrolytes, hypokalemia, hypocalcemia, all these things will cause hypophosphatemia.
Yes.
And one more thing is just go through the Glasgow Blatchford scoring system and the Rockall scoring system, especially for upper the bleed.
Okay. Nothing else. Right.
Okay,
Okay.
thank you.
Thank you.